Hello, everyone. Welcome to Primo Perspective. I'm Kristen Borth.
And I'm Lorie Mills.
Hey, Lorie.
Hi, Kristen. Long time no chat.
I know.
So, we've got some dish today to talk about. So excited. We're
I
going to talk about one of
know.
my favorite things to discuss. And we hear the term, or hear people say all the time, our healthcare system is broken. Our healthcare system is broken. And everybody is pointing fingers at everybody else. And nobody's pointing fingers to themselves as to why our healthcare system is broken.
I mean, why would you point your finger at yourself?
I know. It is crazy. And we're just going to talk about some things, you know, revenues that companies are making, what CEOs are making, and
No.
denials, and just all kind of great stuff that goes on in the revenue cycle. The first thing that I do want to say is a lot of people in healthcare do want to blame insurance companies.
Oh, for sure.
That's the number one blame. And I am not saying they are not have a lot of blame in this. I'm just saying that that's not the only thing that's causing our problems in healthcare.
Yeah. I couldn't agree more.
Yeah, it's insane. We are looking at our top insurance companies. I'm just going to kind of read this off for 2024. And yes, I don't have it on my screen, so I've got good old fashioned paper. I like paper. So United Healthcare, their revenues for 2024 was $400.3 billion. That is astounding to think that.
Could you
But
imagine making that?
I know it's a lot. And I will say this. United Healthcare does have a lot of other arms out there
Yeah.
that they're making revenue. They're not just insurance, but Aetna, $372 billion. I mean, that
Wow.
is a lot of money. But then I got to digging and I said, well, okay, so if our insurance companies are making that, what are our pharmaceutical companies making? And Merck and Company, $64.17 billion in 2024.
Gracious.
Pfizer, $63 billion. And so that made me dig even further. So what else? Our for-profit hospital system CEOs, Tenet CEO, his total compensation package, not his salary, but his total package, $24.6 million in 2024.
Mhm.
HCA's was $23.7 million in 2024. And then I looked at our nonprofit hospitals, and it really, when you start looking at nonprofit, it's very interesting. So the highest paid nonprofit makes $8 million a year. And then
Still.
the next top four were 2 million, 2.5 million, 3 million. I mean, compared to the 24 million, that's a lot.
Yeah.
And so, we hear people say, okay, it's the hospitals are greedy. They're making money, or it's the insurance
Mhm.
companies that's making all the money. But, not only are those people making the money, some of our healthcare cost is because as patients, we don't do what we're supposed to do. We're non-compliant.
Oh, for sure.
Yeah.
And you know who eats that up the most, in my opinion, is usually our pharmaceutical companies,
Yes.
because you get your drugs and then you don't comply with that. And so you need more drugs because
Right.
you didn't comply with it. So
Right.
I agree with you. Those numbers are numbers that I don't feel like the average American,
Mm-mm.
average person, I'm going to say person in the world,
Right. Person.
average person in the world, are even numbers that they fathom. Like
Right.
I couldn't imagine, even at 2 million, making 2 million and not looking at how the healthcare system is broken and feeling a little bit guilty.
Guilty. Oh yeah, guilty. I look at that and I think our healthcare system, because I see it on a day-to-day basis when I'm in
Yeah,
my clients, we have the cost of healthcare is expensive.
it is.
And you and I are HI professionals and everybody knows that some of what we've brought into this space in healthcare has caused this cost to go up.
Yeah.
IT costs. Seth and I were talking about
Mhm.
IT costs. How much
Yeah.
does it cost to implement an EMR in your healthcare system?
Oh,
Um,
yeah.
millions, even some billions of dollars. I've read
Mhm.
where some of the larger health systems that went to Epic, they spent like $3 billion to implement
Yeah.
Epic. That is
Yeah.
huge on a system. That's a lot of money.
Yeah.
We're looking at salaries for healthcare providers. When you think about it, we are some of the best paid professionals healthcare is in the country. I
Yeah.
mean, we make our standard salary is usually above the mean. And
Yeah.
I think we don't take all of that into account when we're talking about how expensive healthcare is.
Yeah.
Would you please share about you have a SDOH presentation you do talking about how much a hospital system saved because when homeless people came in complaining, they offered them something to eat, a sandwich, and it
Yes.
cut down on their cost.
Oh, yeah, it cut down on their cost, by 80+% because they were hungry, but they're coming in to the hospital, and what's the number one thing they say? "Oh,
Chest
I'm having chest
pain.
pain. My
Yep.
arm is hurting and I'm having chest pain." And they know exactly what to say. And as they know exactly what to say, you have to do that full workup. You have to
Yep.
work with them on that because what if there is a situation
Right.
and then the hospital, it all comes back to blame on them, not the fact that they really just wanted a sandwich or
Right.
they were really just cold for the night. And so that cost avoidance that they experienced was huge. And I wish more hospitals were kind of playing that game a little bit more.
Hmm.
And I call it a game because in my opinion, looking at where you could really dive into that cost avoidance because it's not just in your ED. It's
Right.
not just with, the homeless population coming in, but looking at some of those other areas where and I'm gonna say this because we're talking about it anyways, and you've mentioned it to so many people, but when you look at like diabetes and how we have so many that they don't follow what their provider has
Hmm.
given them, just in general and the resources and the amount of time that it takes to help some get back to where they need to be.
Yep.
And I know I'm picking on it a little bit, but it's just one of the hot topics with looking at cost avoidance is where can you focus in some of your resources. And so yeah, I mean, if you look at that, like 80 plus, I think it was about 86%
Hmm.
um decrease, which is
Yeah.
insane. It's insane how much that saves.
Yeah, a sandwich.
Yep,
Decrease their
for a
stay by
sandwich.
86% of cost. Yeah, that
Mhm.
it is strange when you think about it like that, but
Yeah.
we have as a society, we all think or a lot of people think that healthcare should be universal. We should all get
Oh, yeah.
healthcare. And I hear the term a lot of times Medicare for all. And I get tickled and I think, guys, Medicare is not free. I
Nope.
mean, part A, you get because you've paid into the system all these years. They
Yeah.
don't realize that the part B, which covers the outpatient doctor's office visits,
Yeah.
any outpatient testing you may have, ER visits, things like that, that cost base is
Yeah.
250 something dollars a month for part B Medicare. And
Insane.
then you've got to buy your pharmacy plan or your drug plan. It's called a part D plan. The
Mhm.
average part D plan is $50 or $54 a year. And then you've got to have a supplement. And so some supplements you can get for $100 a month, and then some or you may be paying $300 or $400 a month for those supplements. So that's
Wow.
when people start talking about Medicare for all, they're not putting the thought into what that really means.
Yeah.
Uh, it Medicare costs just like anything else. I think we have some places we could really improve in healthcare.
Mhm.
The preventive side. That's
Oh, for
that's a
sure.
huge area we could do, and I don't know that enough people really invest in that like they should. I
Yeah.
know and you're in Arkansas. I'm in Mississippi, and
Mhm.
Kristen's in Arkansas, and so our rural areas, people tend not to take as good a care of themselves as we should.
Yeah.
And therefore, we have a lot more chronic disease
Yeah.
in our areas. I mean, just think Mississippi, we are like at the top of the list, us and Louisiana and Alabama in congestive heart failure. Well, a lot of that has to do
Man,
with the way we eat. I mean, we
right?
eat.
Yeah.
terrible in our region, and that adds to a lot of our chronic conditions that we
Mhm.
have.
Yeah. Yeah. The interesting part about rural healthcare that I didn't know until I was outside of California again as a working professional is that oftentimes in those rural areas,
Hmm.
uh, the residents opt not for healthcare. So
Right.
they opt to avoid it. If I'm
Hmm.
and this was what was said, it's very extreme, but like if I'm going to die, I'm going to die at home. I don't want to be here. And they're
Right.
they're done. They don't go to the hospital. If I'm having problems, I'm going to have those problems at home.
Yep.
And
Yep.
I did not realize that like overarching mentality was there. And that changed a lot of the ways I looked at rural healthcare and kind of getting to the patient just in
Hmm.
general. Because they if they don't want you, how is a healthcare professional who's like, I want to help you, and they're
Yeah.
like, no, but I don't want you
I
there,
don't want your
or I don't
help.
want you here, and you're trying to like, I don't know, you're almost like stalking them to try to get them, but in turn, that is also kind of wasting resources because you are pushing and pushing and pushing, and
Hmm.
they're so against it,
Oh yeah.
so against it in some areas and in some instances.
Yeah. So my dad is 88, and we've talked about him before. You and I have.
Yeah.
He's 88. He just had some really major issues this past year come up where he had to have emergency open heart surgery
Yes.
at 88, and that was a thing that when he went into the hospital that night, I mean, we were transferred by ambulance because he has a blood clot in his
Mm.
heart. And the CV surgeon is talking to him and he's telling him, we're going to do this and do this. And my daddy said, yeah, but I'm going home tomorrow. And I'm
See?
like, no, 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 you're not. But he had in his head that,
Yeah.
he was going to have this surgery and he would be fine and he would go home tomorrow.
Yeah. And my
Uh,
grandparents are the total
mhm.
opposite. They're like overutilizers.
Oh,
Like,
really?
oh yeah, the slightest inconvenience. And I mean, love her to pieces, but my nana is like, "Oh, I have so much pain. I need to go to the ED. Oh, I have this. I need to go to the ED." And my uncle's similar to that with trying to encourage her to go. And so it's been very fascinating cuz
Yeah.
I'm the probably the more conservative person that's like, oh no, I don't think there's anything wrong, I shouldn't go. And then eventually if it gets too bad, I'm like, oh, I should go for
Yeah.
sure. But
Oh,
I'm
yeah.
trying to get to my primary care before that. That's always my policy, trying to
See,
get to my primary care.
and that I think that's where, as a whole, we miss out. We have
Hmm.
so many patients that utilize the EDs or
Yeah.
emergency departments for their primary
Yep.
care,
Yep.
and that is so expensive to do that. My
Yeah.
children used to would say. I would tell them, unless bone is poking out or blood is spurting out, we are not going to the ED.
Yep.
So they kind of grew up kind of hard. They say I was not as maternal as I should have been to them, but
Oh.
it's like we're not going to the ED. But then I used to be an ED coder, and I
Hmm.
would see the same names come through the ED all the time, sometimes 2 or 3 times a week,
Yeah.
and you're thinking, gosh, how are you doing this? How are you paying this?
Hmm.
And most of the time, those bills are not being paid, and
Nope.
providers are having to absorb or write off or put on the cost
Hmm.
report, those losses. And I don't think as a society, we think about that sometimes that
No. I mean, that
we,
is the
yeah,
broken system, right?
mhm,
Right
yeah,
there is like we've directed so much to our ED and we've not allocated like this is what it's for. This is what an emergency is because they have to take whatever comes through their
right,
door to
right.
work on it, right? So
They do.
it's hard for the general population to be like, "Oh, well, I'm not going to wait 3 days to get into my primary care." Now, it may be longer. I don't know.
Right.
Mine has been very fast, but I
Mine
also
too.
live in a very small town. So that could be part of it. But like, I'm not going to wait. I'm not going to be inconvenienced with this anymore. I'm going to go to the ED
Right.
or I literally can't wait anymore. I have waited. I have waited. And that's why we have these crazy, hospital shows where it shows
Yeah.
these extreme cases because they have waited and now they have a tumor the size of, Canada in their body, and it's like, oh no, and they've waited, and unfortunately it could have been something small that we resolved quickly, and now it's a major
Right.
high expense
Exactly.
visit.
Exactly.
So
Yeah,
yeah.
I've had instances, because I've been in, and I'm not shy about talking about my health status, but I've been in and out of the hospitals, and
Yeah.
it just so happened I worked for a facility when I was really, really sick in 2020, and I was in the hospital 12 times that year, and I was in the ICU
Oh,
8
Lorie.
times. And
Wow.
granted, because I worked for a facility, it was not as a financial hardship as it could have been.
Right.
Um, but you look at those charges and you think, oh my gosh. And I think another thing that people don't realize is, yeah, we may charge you $1,000 for an X-ray or say
Yeah.
a CT scan, $2,000 for a
Mhm.
CT scan, but we'd only get reimbursed maybe $200 for that CT scan, and they're
Yeah.
like, well, you're charging me $2,000 for it. Yeah, but it's adjusted off. Your insurance doesn't
Yeah.
pay us that. You have your co-insurance, and then you have what the insurance allows, and we just write the rest of that off. We don't get it.
Mhm.
And that's one reason I laugh about price transparency that we have now.
Yeah.
It's a joke,
Yeah.
because yes, you go on and you can price compare between facilities and things like that. Most people don't even know what they're looking at when they go look
Mhm.
at the charge master on the provider's website. Um,
Right.
and so we calculate. A lot of times people don't realize that providers, especially nonprofit providers, they usually have a self-pay discount, and they usually offer that to you. And if
Yep.
you don't offer, ask, because there is a self-pay discount, and sometimes you can get things cheaper as self-pay than you can through your insurance.
Oh, 100%. 100%. You sent me a video, and I believe his name is Congressman Murphy, Dr.
Greg Murphy,
Murphy.
yes, I know
Yeah.
exactly what you're talking about.
Yep. And he was talking about that and about how, these insurance companies, and I believe that's who he was mainly interviewing, but
Right.
how they will then gouge the price up to the employer that's paying it. So
Hmm.
as an employer, and then someone who gets healthcare insurance, like, talk about that broken system. I mean,
Right.
we're thinking about our employees and like, okay, we need to offer health insurance. We offer health insurance, and then they go to a facility or even a standard checkup, it sounds like. It doesn't
Hmm.
matter. And then they turn around and there's no contract necessarily that says, oh, I'm not going to, require you to pay double for this one, visit.
Right.
So I mean, we've got so many broken
Hmm.
areas, and you started off beautifully by talking about all the broken things with, salaries and profits regarding our, health insurance. And I do not say this lightly. I oftentimes look a lot at our health insurance
Hmm.
companies because they try to point their fingers at our providers, at the facilities, at the patients themselves, at all kinds of things, you name it.
Hmm. Yeah, what I found interesting, talking about the Dr. Murphy,
Yeah.
the congressman, he had just had brain surgery 5 weeks
Yes.
before that video was made, and he made the comment that even if he would have had an LVAD, pumping his heart for him, or been on a respirator, he was going to be at this meeting because he had some
Hmm.
things to say. And one thing I
Yeah.
found very interesting is he said that there was a medication that it took him over a year to
Yeah.
get. He had been denied by his insurance company 8 times for that medication.
Isn't that insane
Yes,
though?
it took 8 times. And I don't understand
Mm.
why it takes that long, and why so many denials. If you need a medication to live, you need it to live.
Yeah.
Um,
Well, and that's where, and I interrupted you.
no,
Sorry.
go ahead. Go ahead.
But that's where I'm very interested to see where this administration is going with some of the I was just listening to Dr. Marty McCary talking
Mhm.
about how we need to take some of these outside of the wall of pharmacy managers and get it on the counter so that you can get it over the counter.
Right.
And I thought that was really interesting because they do price gouge in a lot of
Mm-hmm.
ways. And you just that whole process. Did you by chance read the book Blind Spots by Dr. Marty McCary?
I have not read that.
Okay. Well, I would encourage anybody to read it because he's taking all of the areas that have kind of been blind spots in healthcare where we've just accepted them. And he's like, these are all the broken pieces of healthcare. And he's actually using very specific, not general terms, but very specific things like hormone therapy for women and how it was vilified and now it's starting to come back. But when it was vilified, there was very little research to show why it was being vilified. It was something, very specific that drove them to do that. Same thing with, I'm just thinking of the ones that I was recalling, but breast implants was a huge thing. Vaccinations for that book was a huge thing, but it wasn't, we don't need to vaccinate. It was, why are we not looking at what we're doing with a bigger picture?
Right.
And I just, the book was amazing. I didn't agree with everything, but I think that's the way we go in healthcare, right?
Yeah.
We don't agree with everything, but that's what makes a more balanced healthcare experience. Right. And so,
100%.
You should read it or listen to it if you do audio.
I'll have to check that out. Yeah, that'd be pretty cool to see.
Yeah.
I know one thing that I don't think patients realize is that hospitals and providers have quality measures that they have to meet. And sometimes those quality measures are dependent on a patient being compliant with treatment.
Right.
And when they're not, then providers have to pay a penalty, and it can be in the millions of dollars for a healthcare system to be paying because your patients are not being compliant. One of those is congestive heart failure. So we have what we call the readmissions, congestive heart failure, COPD. Those are a couple that we get readmission penalties for, and patients don't realize. Okay, so if my doctor puts me in the hospital and I get well and I'm to a point where I can go home, if I'm non-compliant when I get home and I go back in the hospital within 30 days, then they're penalized for that. And I don't think our patients really understand that.
No, I don't think so either. And I think there's, in a lot of ways, I would say there's some reservation in some way for the hospital to kind of announce that. And I'm not saying they should advertise it, because then that would seem a little odd too. But at the same time, stressing the importance of patient compliance with their treatment plan and really getting some really honest feedback. Because sometimes I think patients say they're going to comply because they're scared to say they don't want to do that. I can't tell you how many times during, my pregnancies, I would get pushback when I said, no, I don't want to do any, genetic testing. Why don't you want to do any genetic testing? What's wrong with you? What's happening? And I got so much pressure that at times it was like, okay, well, maybe I should. And it was so intense. Whereas, and I'm a healthcare professional and like thinking about patients who are not, I think that scares them to say no. So having a safe, I use this term, don't judge me by it, having a safe space with their health, I know, but a safe space with their healthcare provider. And maybe it's not their doctor, maybe it's a nurse, maybe it's somebody else, but having a space to say, I don't want to do that. I don't like taking all those medications. That's hurting me. What, like it makes me sick or it makes me feel bad. What other options are available? And sometimes it's unavoidable. Let's be honest.
Yeah, sometimes it is. Sometimes, in my instance, I don't have a choice. I have to take insulin. I'm a type 1. I have to take insulin. And, I feel bad. So when I change my pump out, sometimes I'll have to waste some insulin.
Mm-hmm.
And it just makes me crazy because I see all of these people on Facebook and social media, talking about they have to ration their insulin because it's so expensive for them to get insulin, and they're just really struggling. And so if I waste 10 units, that makes me feel so
Yeah.
guilty. I do. I
Yeah.
feel really bad about it. But there's lots of things we can do. And you and I have had this conversation. I am not the most compliant diabetic in the world. And so sometimes things that happen to me are my own fault. And I do try to do better most days.
But that's
But
being human.
yeah, I think so too. And I think a lot of times when you have chronic disease, sometimes you get to the point of you're over it. You don't care
Yeah.
anymore. You just whatever, I'm not gonna do that. And I think maybe we need to address those mental issues as well.
Yeah.
And the mental health aspect of being a chronically ill patient. And sometimes I think that would help some of our chronically ill
Mm-hmm.
patients maybe do better and be more compliant. Um,
Yeah.
one of the other things I want to talk about, and you and I've had this conversation before, is just how expensive it is for providers to treat patients. I mean,
Yeah.
we talked earlier, a CT, just a basic CT or CAT scan machine, you can't get for less than $1 million. And that's like a
Mm-hmm.
cheap one. And you're talking about small rural facilities trying to provide
Yeah.
health care to their communities. And, my CT scanner is $1 million. I have an MRI truck that comes in once a week because I can't afford to buy an MRI machine.
Yeah. I
Things
just got
like
a new
that.
EHR.
Yeah. New EHR.
Yeah.
Speaking of EHRs, and we've talked about this before, um, last year, Epic, their revenues were like $5.7 billion. And for people that don't know, Epic is one of the main EHRs
Yeah.
in the country. They own most of the market. But not only are you implementing that EHR, you have to hire so much more IT staff
Yeah.
to handle that product that you have in your facility, and that's causing costs to go up. I mean,
Yeah.
there's a whole, when we talk about the broken healthcare system, there are so many pieces to that
Yeah.
I don't know that we can fix all of them, but there are some things we could do to fix some of them.
Yeah.
Um, just I don't know. I feel bad for providers. I laugh. I say I laugh when you hear a lawsuit come out or that somebody has been arrested for committing healthcare fraud. My first reaction is, how do you make $3 million committing healthcare fraud? It's hard enough to get a clean claim out and paid on time. How are you getting $3 million
Yes.
worth of fraudulent claims paid?
Yes. That is the
That is
comedic side
shocking.
of it. That's the
Yeah,
comedic side of it, though,
yeah,
is like we can't get normal claims paid. And you hit
right,
on like a really important topic. We can't get normal claims paid, but yet there's somebody out there, and they're doing it right now,
right.
and they're getting paid millions of dollars for what? Like what was their secret sauce so we can use it to get our normal claims paid?
Yeah. Let's
Oh,
make that part of like parole for these
yeah,
guys that are getting these
exactly.
fraudulent claims paid. Come teach us how to do that so we can get paid on time. I mean,
Yeah.
it's insane. Um, Another thing, we talk about that, but it's just such an issue. We talked about the abusing the clinics and things like that, but just providers trying to get services approved for their patients.
Oh,
Getting authorization for some things is just so difficult.
yeah.
And in another thing, inpatient care, people think that, okay, I'm going in the hospital and I'm spending the night. I'm an inpatient, what we call an inpatient. And we know that's not true.
Yeah.
And so I may go into the hospital and I may stay 3 or 4 days, but my insurance company can say, no, we don't consider that an inpatient. They weren't sick enough to be an
Yeah.
inpatient. So we're going to pay you what we call an observation patient. So where I might
Yeah.
would have gotten paid $6,000 for this inpatient, my insurance company saying, no, you're an obs patient. So they pay $1,500, but the patient gets the same care
Right.
regardless of
Yeah.
what status they're in, whether they're an observation or an inpatient, they're getting the same care.
Yeah.
And so my take on that is, well, if we're transitioning everything to outpatient, why not increase our outpatient payments that we're getting from
Right.
insurance? And unless, okay, you want to transition from in, let's go to out, but you got to pay me
Yeah.
more.
Yeah.
You've got to pay me
Well,
more.
that's where this war on prior auths is like a, I don't know, a soap opera kind of, where you're like
It is.
watching, because you don't know what's going to happen. I mean, I don't know what's going to happen. I like the idea of us literally going to war on prior auths and trying to fix it and fix the process. And it's
Mm-hmm.
only one of the broken parts, but at the same time, I don't know if it would come out any better
I know.
if they do it that way. I don't know.
Yeah. Well, I think one thing, and we see this, is doctors are so frustrated because they're having to spend, and not just doctors,
Yeah.
providers, nurse practice, PAs, all the
Oh
advanced
yeah.
practice providers as well. They're having to spend so much time trying to get these things approved because insurance will say, I want to do, we have to do a peer to peer, which means the doctor has to talk to another doctor to get it approved. So instead of seeing patients,
Yeah.
he's spending 45 minutes on the phone to talk to another doctor to explain why he's wanting to do this test on his patient who the doctor at the payer has never laid eyes on, doesn't know
Right.
anything about this patient.
Yeah.
Um,
Yeah.
so I find that very interesting. So you're talking about the prior auth. It is going to be interesting to how that goes.
Yeah.
For a long time, we never had to have prior auths for Medicare. Well, now Medicare's got a few services that you have to have prior auth for before you can have it done, because they're trying to
Wow.
trial that out to see, is that the way they want to go in the future, is having prior authorizations for tests. So
Wow.
I feel like we're going to see a big shift in prior auths, whether it's for the good or for the bad, but something's got to change. It really does.
Oh
We
yeah.
can't keep going this way.
Yeah. It's true. It's true. And we've touched on all of these broken pieces, and we like to dog on healthcare kind of in general.
Yeah.
Because like, oh, that part's broken and that part's broken, but yet there are still thousands of people who come to the US to get healthcare, and
Right.
they pay cash to get healthcare
Mm-hmm.
because they don't have our insurance. They don't understand. And we are still competitive.
Right.
And I won't claim to know what the top one is. I don't know what the top healthcare, country is for healthcare services, but I
Right.
know we are still among the top.
Oh,
And
yeah.
I know, and I think this is because I'm in healthcare, I know that there is so much heart in healthcare,
Mm-hmm.
but like our single hospitals, I think we are administratively bloated when it comes to
Mm-hmm.
healthcare. And so I think that's part of the problem.
I think
So,
it is too. It really is.
yeah.
And back to our healthcare system, I think we have one of the best healthcare systems in
Yeah.
in the world.
I do too.
And I wouldn't want to go anywhere else. I mean, when we travel, because I've traveled out of state, out of country, and it terrifies me because
Yeah.
I don't want to end up in a facility in another country.
Yeah.
I've always wanted to do like a mission trip, a church mission trip to South America. Our church has gone to Peru and different things, and I want to go so bad, but I'm terrified to go because what if something happens to me while I'm down there? Yeah, I may be
Right.
with a medical team, but
Yeah.
where are they going to put me and what's going to happen? So I kind of am a
Yeah.
little nervous about that, but yeah,
It's
I think
true.
we do have great care here in the country, in the United States. And I don't know what's going to happen in the future, but I know that something's going to have to happen one way or the other. And like
Yeah.
I told Seth earlier, there's enough blame to go around to everybody
Oh,
as to why our
100%.
system is broken. It's
Yep.
not one entity.
No.
Granted, I have my opinions of what I think the largest contributor is, but I mean, we all have some blame to go
Yeah.
around for it.
Yes.
And so going forward, I don't know what's going to happen with it, but hey, I'm here to help make it better. That's all I know to do.
Agreed. Agreed. I'm here for that reckoning. As I said,
Yep.
in our introduction to why we're doing this, I'm here for that reckoning, and I'm ready to, put the heart that I have for our profession into helping resolve it and fix it. So
Hmm.
I'm excited. I'm excited.
I am too. I think we're on the edge here, and things are going to change, and
Yeah.
I'm glad that we're going to be a part of that for
Yeah.
sure.
Oh, me too. Me too. Any closing thoughts as we finish up?
No, not really. Other than, as always, guys, if you have any questions, reach out. I don't know how many non hospital healthcare people are seeing this, but we always answer questions about Medicare
Yeah.
coverage for traditional Medicare and things like that. So if you have someone that's wanting to get a Medicare Advantage plan and you don't want them to, hey, send them our way. I'll be glad to talk to them and tell them what I know. That is just a patient service that we offer.
Yep.
For Primo is to talk to seniors about Medicare and things like that. So, hey, we'd be glad to talk to them and answer any questions they may have.
Absolutely. Absolutely. Well, until next time, Lori.
Later.